Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Welcome back to the Deep Dive. Today we are grabbing our emergency kit and diving headfirst into one of the messiest, probably most debated areas of emergency medicine, medical toxicology, decontamination. Our mission really is to understand how we stop toxins or xenobiotics, those substances, from actually being absorbed by the body, whether they come in through the mouth, the skin, the lungs.
It's a critical area, and the field has seen a definite shift, moving toward less aggression and, frankly, more hard evidence.
Right.
I think the single biggest takeaway, if you remember nothing else, is that routine automatic administration, that sort of knee-jerk response we used to see, that's heavily discouraged now.
Okay, so no more just automatically reaching for the charcoal or starting irrigation. We're unpacking the main tools: activated charcoal, AC, and whole bowel irrigation, WBI, and trying to figure out exactly why the specific drug or poison involved forces such complex case-by-case decisions.
Exactly. What's kind of fascinating is that GI decontamination, it used to be a cornerstone, right? First step in managing poisoning. But now, honestly, we spend more time figuring out when not to use it.
Okay, I have to ask, why the shift? I mean, logic seems to suggest if there's poison inside, getting it out is good. Why are we sort of stepping back from that aggressive stance?
It boils down to proof. It's incredibly difficult to actually prove that these methods improve the outcomes that matter most, like does the patient survive? Does it reduce morbidity?
Huh. Why is that so hard to prove?
Well, poisonings are messy, patient histories, often unreliable, sometimes completely wrong. Plus, many exposures are actually pretty low risk anyway, so doing a rigorous clinical trial comparing an intervention to doing nothing, ethically complex and often doesn't show a clear benefit.
So, okay, if we can't rely on this idea of a blanket benefit, we have to become like poison detectives for each case. What are the key things you look at to decide if a procedure is even worth the risk?
You're essentially balancing four main factors. One, the specific toxin, what are its properties, how dangerous is it? Two, the patient's clinical status. Are they awake? Can they protect their airway?
Right.
Three, the risks versus the actual benefits of the decontamination method itself. Is it likely to help this patient with this toxin? And four, time. How long ago did the exposure happen?
That makes sense. It sounds really complex.
It is, and that complexity is precisely why expert consultation, often getting a medical toxicologist involved, is so important for developing a targeted, goal-directed plan.
Okay, let's talk about the old workhorse then.
Yeah.
Activated charcoal, AC, the gritty black stuff,
Mm-hmm.
used to be everywhere. How does this adsorbent powerhouse actually work? How does it bind toxins?
Right, AC. It's basically a very complex carbon material, often made by superheating things like coconut shells in a low oxygen environment that's called pyrolysis and then activating it.
Activation.
Yeah, it creates this incredibly porous, almost sponge-like structure inside the charcoal particle.
And when you say porous, you mean the surface area is just huge.
Oh, it's immense, physically enormous. To give you an idea, a single gram of really good activated charcoal can have a surface area up to maybe 3,500 square meters.
Wow, per gram.
Per gram. And that massive area is what allows it to absorb things, basically binding substances onto its surface through relatively weak intermolecular forces.
Okay, so what does this internal sponge like to grab onto? What binds best?
It prefers things that are dissolved, non-ionized, and generally organic compounds. Usually we're talking about xenobiotics with a moderate molecular weight, say between 100 and 800 Daltons. If it's lipophilic, fat-soluble, it tends to bind pretty readily.
Got it. Now, the critical factors for success. We know timing matters ideally within the first hour, maybe some effect up to 4 hours. But what about the dose? Stoichiometry, right?
Stoichiometry is absolutely crucial. It's the chemistry term for getting the dose right, making sure you have enough charcoal binding sites for the amount of toxin ingested. You need a high charcoal to drug ratio.
Hi.
Well, historically, people talked about 10.1 charcoal to drug, but some experts now argue that for really effective absorption, you might need something closer to 40.1.
40 to 1. That sounds
Yeah.
challenging. Less like a standard procedure and more like a serious logistical hurdle, especially in a busy ER.
Yeah.
Try to get that much charcoal down quickly.
It's a very significant challenge, and that speaks directly to the real-world limitations of AC. If you can't achieve that high ratio, the binding capacity just isn't there. And then you've got interference to worry about, too.
Interference, like what?
Things already in the stomach, food, milk, even some thickening agents used in liquid medications, they can compete for those binding sites on the charcoal, making it less effective.
Okay, let's talk about the hard limits then. The AC won't bind list. If the poison is on this list, AC is basically useless.
Essentially, yes. The big categories are metals, especially salts of iron and lithium. AC doesn't touch them. Also, hydrocarbons, caustics like strong acids or alkalis, and the toxic alcohols, methanol, ethylene glycol.
What about cyanide?
Cyanide and the toxic alcohols. Well, there might be some minimal absorption, but the amount of charcoal you'd need to make a clinically significant difference, that stoichiometric ratio, it's just impractical. So effectively, AC isn't considered useful for them.
And the risk of AC itself. The big fear is always aspiration, getting it into the lungs. But the sources suggest it's not just the charcoal's fault.
That's a really important point. Yes, aspiration pneumonitis is the most common serious complication, but the evidence suggests it's less about the AC itself causing aspiration and more about the patient's conditions, specifically a decreased level of consciousness. If the patient can't protect their airway, that's the primary risk factor.
So airway management is key.
Absolutely. Securing the airway is the critical step, not necessarily avoiding AC if it's otherwise strongly indicated and the airway is safe.
Before we leave AC, quick word on multiple dose activated charcoal, MDAC. Why keep giving doses?
MDAC is different. It's not about initial binding. It's about enhancing elimination later on. It's reserved for a very specific list of drugs, ones that undergo enterohepatic or enteroenteric recirculation.
Meaning they get secreted back into the gut.
Exactly. They circulate from the liver back to the gut via bile or directly from the blood into the intestine. Repeated doses of charcoal interrupt this loop, trapping the drug in the gut as it's resecreted, preventing reabsorption and speeding up removal from the body. The classic examples are drugs like theophylline, phenobarbital, carbamazepine.
Okay, so if AC is like a chemical filter or sponge, what happens when the toxin can't be filtered like those metals or the dose is just too massive for the sponge?
We need a physical reset, right? That brings us to whole bowel irrigation, WBI.
WBI is exactly that, a mechanical flush, purely physical. It involves giving large volumes of a special solution called polyethylene glycol electrolyte lavage solution, PEG-ELS, usually through a feeding tube, sometimes orally if the patient can tolerate it.
And this PEG-ELS stuff, what is it? It's basically a balanced isoosmotic solution. It contains polyethylene glycol, which is an osmotic agent that holds water in the gut, plus electrolytes balance so you don't get major fluid shifts or electrolyte problems. The goal is just to flush everything through the GI tract very quickly, often within hours.
So WBI steps in where AC fails, particularly for metals or those tricky slow-release drugs.
Precisely. Its main indications are for substantial ingestions of things AC binds poorly, like iron or lithium. It's also really important for modified release or sustained release pharmaceuticals.
Why specifically those?
Because those formulations are designed to release drugs slowly over many hours. They can sit in the gut, continuing to cause toxicity. WBI physically pushes them out before they can fully release their contents. And of course, it's the standard for body packers, people who've swallowed packets of drugs. WBI helps expel those packets.
Okay, practical question. What if a patient seems like a candidate for both AC and WBI? Which do you do first?
That's a good point. Generally, the recommendation is to give the dose of AC first before you start the WBI flush. There's a theoretical concern that the huge volume of PEG-ELS solution rushing through could potentially cause the drug to desorb or unbind from the charcoal it just attached to. Giving AC first allows some time for binding before the big flush starts.
Makes sense.
Yeah.
And when is WBI definitely not an option?
Yep.
What are the contraindications?
The big ones relate to gut function and airway safety. You absolutely need an intact and functioning GI tract. So any patient with an ileus where the bowel isn't moving, either mechanically blocked or just not contracting, WBI is out.
Okay.
Also, significant active GI hemorrhage is a contraindication. And similar to AC concerns, an unprotected airway or uncontrolled vomiting is a major issue because of the risk of aspirating that large volume of PEG-ELS fluid.
This is where it gets really fascinating for me, connecting the drug's own behavior, its pharmacokinetics, to which decontamination method you choose. Especially with these modified release drugs, there are some surprising findings, right?
Absolutely. Overdose pharmacokinetics can be very different from therapeutic kinetics. Take quetiapine, for example, an antipsychotic. One study showed that single-dose AC reduced absorption by about 35%, even when given, on average, 3 hours after ingestion.
3 hours. That's way past that 1 hour window we usually talk about for AC. How could it still work?
Well, partly it's because large overdoses often cause delayed gastric emptying. The drug just sits in the stomach longer. But critically, with quetiapine, up to half of overdose cases can form something called a pharmacobazor. Lefracobazor. It's basically a clump, a solid mass of undissolved pills stuck together in the stomach. It acts like its own sustained release formulation, slowly dissolving over hours. So if that bazor is still there 3 hours later, AC can still bind the drug as it dissolves.
Ah, so the drug is effectively still available for binding much later.
Yeah.
What about citalopram, the antidepressant?
Citalopram showed a really interesting dual effect. Yes, SDSC reduced bioavailability, how much got absorbed, by about 22%. But intriguingly, it was also estimated to increase the drug's total body clearance by around 72%.
Increase clearance. How?
The thinking is it might be acting like a sort of gastrointestinal dialysis. Even after the drug is absorbed into the blood, some might diffuse back into the gut lumen, and the charcoal sitting there can trap it, preventing reabsorption and pulling more out of the system.
Okay, let's look at venlafaxine extended release. This one highlights why sometimes you need both AC and WBI.
Right. Venlafaxine XR overdoses can be nasty, often causing seizures. And the predictor for severe toxicity like seizures is often the peak concentration, the Cmax. A key study found that combining SDAC with WBI led to a much bigger reduction in that peak concentration compared to just giving SDAC alone.
Why the combo?
The WBI is crucial there for flushing out those extended release pellets or tablets before they can fully dissolve and release all their drug, thus blunting that dangerous peak. The AC gets what's already dissolved, and the WBI gets rid of the remaining source.
And one more salicylic acid, specifically enteric-coated aspirin.
Yeah, enteric coating is another form of modified release designed to bypass the stomach. Because it delays and prolongs absorption down in the intestine, WBI was shown to be better than using charcoal mixed with sorbitol, a cathartic. The WBI mechanically clears that source material from the entire bowel, preventing those delayed, often severe peaks in salicylate levels that can happen hours later.
Okay, we spent a lot of time on things people swallow, but obviously contamination happens through the skin, eyes, lungs too, especially in, say, occupational settings. Let's pivot to those non-GI routes.
Good point. And the absolute first rule for any non-GI exposure before you even touch the patient is personnel safety. Put on your PPE gloves, gown, eye protection, whatever is appropriate to avoid becoming contaminated yourself.
Okay, safety first. Then for skin exposures, what's the most critical action?
Promptness. Speed is everything. Get contaminated clothing and any jewelry off immediately. Then, irrigate the skin copiously. Just lots and lots of water is usually the key, especially for corrosive chemicals. The sooner you dilute and wash it off, the less damage it can do.
And the eyes. They're so vulnerable.
Extremely. Again, immediate and copious irrigation is vital, usually with water or sterile isotonic saline. For significant chemical exposures, especially alkali or acid burns, we often use a device called a Morgan lens.
What's that?
It's like a special contact lens with tubing attached. It sits on the eye and allows for continuous, gentle flushing of the entire surface under the lids everywhere for an extended period. It's much more effective than trying to manually irrigate for, say, 30 minutes or an hour.
Right, and inhalational exposures.
Right.
Common in workplaces or accidents.
The single most important step is removal from the source. Get the patient out of the contaminated environment and into fresh air immediately. That stops ongoing exposure. With occupational toxicology, you're right, inhalation and dermal routes are primary. And taking a really detailed occupational history is crucial because the link between someone's job and their illness might not be immediately obvious.
This whole deep dive really drives home the point, doesn't it? That treating poisoning isn't about following some old recipe. It's shifted entirely to this precise, real-time risk-benefit calculation. You're constantly weighing the specific toxin, the time since exposure, the patient's condition, and the limitations of the decontamination methods themselves.
Exactly. It's nuanced decision-making, and it's why in complex or uncertain situations, using resources like the ATSDR, the Agency for Toxic Substances and Disease Registry, or calling for a consult with a medical toxicologist is so valuable. The guidelines are moving away from routine use because specificity, targeted therapy is what truly helps patients.
So here's a final thought to chew on. We learned that single-dose activated charcoal works best within that first hour, and its real power might depend on hitting that massive, maybe 40.1 charcoal-to-drug ratio. Given the practical nightmare of actually getting that much charcoal into a sick, possibly uncooperative patient that quickly in a high-stress ER, how much does that sheer logistical difficulty limit its real-world usefulness, regardless of what the lab studies say about its potential efficacy? It's something to think about when you hear the guidelines.
That gap between the theoretical ideal and the practical reality is huge. It's often where the toughest clinical decisions have to be made.
Absolutely. Until next time, keep digging into the data.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.